Hello, this is Dr. Robert CYWES, and I want to thank the Nutrition Network and everybody that's worked so hard to bring this wonderful, wonderful summit together. I'm a clinically practicing doctor working in the ketogenic metabolic space. I treat children and adults, and I work in Florida in the United States. But today we're going to discuss my clinical use and clinical understanding of uh, blood work that we do on a regular basis in the office and how we interpret that. Our learning objectives are to understand the relationship between a low carbohydrate diet and really what we consider to be biochemically measurable optimal health, and to be able to see the clinical implications of that. We want to use the blood work to make improved medical decisions, both in terms of medicinal therapeutic intervention as well as behavioral intervention for disease resolution, and also to use the blood work as a platform for deprescription and monitoring. And finally, we really want to reinforce the use of the blood work to differentiate between causality of disease from just markers of disease. Because of course, we don't want to treat a marker, we have to treat something that actually causes disease. So one of the common concepts out there is that obesity causes a lot of diseases, and the traditional simplistic caloric model is that when you consume energy, you have a certain set point, and if the energy in exceeds the energy out, you gain weight, and that causes all kinds of metabolic problems, or physiologic conditions, growth, weight, obesity. And therefore, the paradigm of every diet is caloric reduction. And if caloric reduction results in weight loss, that is the fundamental of every diet. But this is way, way too simplistic. Because what that simplistic calories in, calories out model fails to understand is human biology. Because the caloric impact is always purpose driven. In other words, what we've got to ask as clinicians, we have to ask the question, why is this person consuming the calories they're consuming, and what is the impact of that caloric consumption? This for me is the most important rule of nutrition. Caloric impact is always purpose driven. Why are the people eating the way they are? And from a biologic perspective, there are really two reasons why we eat macronutrients. First of all, for daily energy required for endurance, for performance, for storage as a storage source for energy, and then for thermoregulation, for temperature regulation. However, macronutrients are also used for growth, for tissue repair and healing, for strength, for muscle building, as part of daily cellular turnover, autophagy, repair, regeneration. So a purpose-driven hormonal imbalance defines caloric impact. In other words, the purpose that the body is subjecting that caloric impact to defines the imbalance. And quite simply, obesity, the purpose of caloric consumption for when someone's obese is for emotion management. But as seen here, the purpose-driven hormonal imbalance defines the caloric impact. So when you're growing as a child, you're gaining weight, you're eating calories in a distinct forward-moving growth cycle. For endurance, you're burning through those calories, you're using them for endurance, even though you're very lean. Whereas a power builder may be gaining muscular strength and may be gaining somatic size. That's the purpose of their caloric intake. And there are certain hormones associated with growth, associated with endurance, associated with strength training, as well as tissue repair healing. In this diabetic that's healing, there is a natural deposition of storage. This is someone with lipedema, but that's a completely normal, natural, genetic process, as opposed to global obesity, which is a hormonal imbalance that is caused by chronic excessive carbohydrate consumption. And we're going to look at the hormonal imbalances in our blood work. Then there are environmental strategies for caloric impact. In the Khoi, the sun, the so-called Bushmen in my part of the world, they're very lean because of the heat, whereas the Eskimos have some more body fat because of thermoregulation. So a high carbohydrate, low fat diet, let's focus on that because we're not going to talk about those other forms of caloric impact. A low-carb, high-fat diet is a diet that creates insulin resistance by forcing the body into a state of hyperglycemic hyperinsulinemia, resulting in inflammatory glycoliposis and other diseases. That is the hormonal balance from chronic excessive carbohydrate consumption in response to emotional need. So that's what we're going to look at as we look at ketogenic blood work, because it's the restoration of that process that we want to measure. And what does a healthy person look like? A couple of metabolic blood work concepts. The first one is that healthcare in my generation has shifted from primarily a diagnostic approach. What is the root cause of this person's disease, and can we modify the root cause to get rid of the disease? Toward a primary therapeutic paradigm where we do tests, we figure out what's good and what's bad, and we throw medications or surgeries at what's bad without ever understanding or walking this back to root cause. Root cause diagnostic evaluation, unfortunately, is becoming less and less well understood or tested for in terms of biochemistry and in terms of understanding physiology. And this is particularly important when it comes to diseases that we cause to ourselves. Ketogenic blood work is all about understanding biology and pathophysiology and allowing the numbers to tell a story of disease or a story of improving health. And the key thing about numbers telling stories is that no one number tells a story. All stories require interactive corroboration. So when we look at one number, the diagnostics are going to be supported by a collective set of numbers that all modify or qualify that particular number. So our foundational thinking in a ketogenic healthcare paradigm is away from treating disease externally with medications toward helping people with the best possible treatment to treat a disease they've caused themselves, obesity, metabolic syndrome, diabetes, with therapeutic carbohydrate restriction. And then the blood work is there to monitor the severity of that disease and its improvement. Sometimes, of course, we need to throw medication. Somebody may have profound type 2 diabetes, may need medication for that while they're going through therapeutic carbohydrate restriction to put that diabetes into remission. Supplementation may also be necessary, and we need to monitor that. One of the other keys about metabolic management is that we need to understand inflammation, and inflammation occurs in the human body due to sugar in 4 different spaces: in the gastrointestinal tract, irritable bowel, gastroesophageal reflux, inflammatory bowel. Intravenously, we call that process diabetes or insulin resistance. In the interstitial space, where we get fibromyalgia, we get stiff joints, we get gout, and then intracellularly, where we can get brain injury, dementia, we can get autism spectrum disorders, we get cancers, we get a variety of autoimmune and inflammatory conditions. Next, the healthcare shift, the paradigm that we work in is to be able to distinguish based on the blood work the carbohydrate insulin model of obesity, diabetes, and metabolic disease, and be able to distinguish that from the lipid heart hypothesis, which is crucial. And part of the monitoring, be it not the biochemistry, we ought to help our patients to monitor their own blood sugar, their own blood pressure, their own heart rate and rhythm at home, so they can give us that feedback information. But part of this is not being paternalistic as a healthcare provider, but helping patients to become their own providers based on feedback paradigms that you set for them. When we do blood work, from a practical perspective, it should be done early morning fasted, approximately an 8 to 10 hour fast to capture the dawn effect, which hopefully is the worst but most consistent blood work we're going to see during the day. So let's look at carbohydrate and sugar and starch. Increased carbohydrate consumption has put us ahead of Homo sapien evolution. In other words, the genetics of our body cannot cope with excessive carbohydrate consumption. And when carbohydrates break down, they break down to carbon, to hydrogen, and to oxygen. Those are the 3 molecules involved with carbohydrates. So to understand what normal is, and this is going to influence our blood work, an insulin sensitive person at variable times throughout the day either uses glucose as a primary cellular substrate or uses ketones. Ketones readily cross into the cell by default anytime the sugar is inadequate. And one of the key things to understand about insulin receptors, glucose flux into the cell, it is directly controlled by the energy ratio. In other words, the cellular production of energy in the mitochondria is a feedback system for entry or blockade of glucose into the cell. And that we call the AMP-ATP ratio. When your ATP ratio is high, you've produced a lot of energy, you don't need energy coming into the cell. Whereas where your AMP is high, you want that energy to come in, and then if you're insulin sensitive, it may be under the influence of glucagon, where it's going to be ketogenic, or it may be under the influence of insulin during and after meal times, where it may be glucogenic. When the system goes awry, when you've got chronic excessive carbohydrate consumption and there's excessive carbohydrates in the bloodstream, the cell is continuously flooded with an overflow of sugar. And therefore, the ATP ratio is high, and the feedback to the insulin receptor is to shut it off and to minimize the number of exposed insulin receptors. So therefore, the cell is flooded with insulin, there's no ketones available, and the blood sugar goes up because you can't shove that blood sugar into an already overflowing cell. However, on the other side, when somebody is on a ketogenic diet, they may be so fat adapted that their cells prefer ketones. And under those conditions, when they're not eating sugar at all, they slowly become insulin suppressed, where their cellular energy is primarily coming from ketones. Their ATP ratio is high because they're in a constant state of ketosis, and they don't need sugar, therefore they do not release a lot of insulin to shove that sugar into the cell. And they're not eating sugar, so at first the blood glucose level normalizes, but then they're eating a lot of protein. The protein gets turned to sugar by the liver. The sugar has nowhere to go, so their blood sugar goes up, and they can't get into the cells because it's flooded with ketones producing ATP. There's no trigger for those insulin receptors, and we call that insulin suppressed. And we have to make note of all of those in the ketogenic space. So let's go on. Let's talk about blood sugar. An ideal blood sugar, a normal blood sugar for a human, is around 83, between 80 and 85, and that's my target blood sugar. Now, in the early morning, in the dawn effect, it may go up to 90s, 95, maybe even 100, but I certainly want it below 100 typically. And I'm going to use American units. Sometimes I will show the metric units. But we have to account for the dawn phenomenon. That's absolutely fine. But anything above 95 starts to cause me concern. But blood sugar is an instant in time. What's more valuable is the hemoglobin A1C. And the key thing to understand that hemoglobin A1C is a measure of average blood sugar. And it is average blood sugar. It is the amount of sugar over time in the bloodstream that damages the cells, the endothelial cells, and causes vascular injury. And an A1C below 5.2, at or below 5.2, is the point where the average blood sugar is no longer a factor in vascular injury. Above this, in my opinion, you begin to see insulin resistance, and you begin to see measurable elements of vascular resistance. So that is a radical shift down in terms of what a normal A1C is. In fact, if you look at at insulin resistance, I personally have divided it, as I look at my patients, into two separate types. At first, we have type 1 insulin resistance, where we see relatively normal blood glucose, but a high fasting insulin. So the pancreas is having to work harder to normalize that blood sugar. But then over time, it becomes a type 2 insulin resistance, where you now have an elevated fasting blood sugar and an elevated insulin level, but a normal A1 or an A1C that is below 6.5. And then once the A1C chronically gets above 6.5, now we're in the territory of type 2 diabetes. And I would argue that the time to start treating patients with diabetic medication is when they're in that type 2 insulin resistance. Don't wait for them to be true type 2 diabetics. Now, our insulin, a normal insulin for me, a normal fasted insulin, is somewhere around 4 international units, maybe 4 to 6. And in fact, the problem with type 1 diabetics who cannot produce insulin, so this is at a very low number, but the problem with type 1s is not their insulin. It's the type 2 component, the insulin resistance, because they're eating a lot of carbohydrates. Now, in parallel with insulin, we look at C-peptide, which is what the pancreas produces, and ideally we want the C-peptide to be between 1 and 1.2. If it's below 1, certainly if it's close to 0, we're looking at type 1 diabetes, or potentially we're looking at a fat-adapted, insulin-sensitive, or possibly even insulin-suppressed person on a low-carbohydrate diet, and we'll see that as a Kraft 5 graphic. Glucagon we test quite a bit, but I don't give normal numbers for glucagon. I just want the glucagon in the early morning to be at the lower 1/3 of the normal range, despite the fact that the person is fasting. So for most of my lab work, it's below 20, but it really depends on the lab. That's why I can't give you a number. We always, at least once in our diabetic population, will check the glutamic acid decarboxylase, the insulin autoantibody 1 and 2, because so often in my practice, type 2s come in and they don't understand. They're doing carnivore, they're ketogenic, they can't understand why they're not getting better, and they actually have latent autoimmune diabetes of adulthood, or LADA. And it's so important and so easy to identify that. So we have to be able to establish, is this person a 1, a LADA, or a 2? And we do that with this blood work. Sometimes, not always, but sometimes I will use, when there's a confusing picture, a glucose tolerance test, and I'll look at those Kraft levels. The glucose tolerance test must include glucose and insulin measurements, and I've given the hours and the minutes that we do it for there, after an 8 to 9 hour fast, and it should be a 75-gram bolus of sugar. Ideally, we should get glucagon and ketone levels as well, but that doesn't always happen. And the Kraft pattern will reflect the type 1, type 2 insulin resistance, insulin sensitivity, or insulin suppression, which is the word that I've created for that group of veteran carnivores. We do check ketones. I simply just use ketones in the urine because it's good enough. But if you do test blood ketones, they should be ideally between 0.3 and 0.5 to 2, but definitely not above 5. Above 5, you start getting acidosis, you start getting into DKA, and that's a concern. I never look at ratios. I look at raw numbers because the ratios can lie to you. So HOMA-IR and those kinds of things, I ignore all of that stuff. I look at the raw numbers. And CGMs, the Dexcom 6 is my favorite, soon to be the Dexcom 7, is a very valuable tool in this population. Now, with the Kraft tables, as we look at the patterns, and we don't do this very often, but we look at two things. We look at the fasting blood sugar, and we look at the fasting blood glucose, and they should both be low, in that 80 to 85 range and in the low range. Then we should see a rapid rise in insulin commensurate and reactive to a rapid rise in blood sugar, and it should bring the blood sugar down very nicely. If that response is delayed, that's type 1 insulin resistance with still a relatively low fasting blood sugar. If the fasting blood sugar is higher and we see much more delayed response, that means that the blood sugar is high, and often you have a reactive hypoglycemia episode. That's insulin resistance type 2. And then if the response is markedly delayed with a high starting blood sugar, we're dealing with type 2 diabetes. Our obesogenic patients who have pretty close to zero risk of becoming diabetic are able to produce massive amounts of insulin. Their picture may look like they're an IR1 or IR2, but they do not go on to develop type 2 diabetes because they can produce massive amounts of insulin, and even their fasting insulin is very raised. But that's a different picture to someone who's a type 2 diabetic. In our Kraft pattern 5s, we see a flat insulin curve, typically below 30 units, despite the high rise and prolonged rise of sugar. And that occurs, that's pathognomonic of type 1 diabetes, but it also occurs in our insulin suppressed patients. Identical picture. So now let's talk about protein, nitrogen. We've talked about sugar, we're going to talk about nitrogen. The nitrogen balance is very important because the human body has no place to store protein. It cannot store protein. So nitrogen balance is either net use of nitrogen, of protein, or net removal of protein, converting it to sugar or to fat, or getting rid of it. So where does protein and purine come in? Nitrogen, proteins, by the way, amino acids, are carbon, hydrogen, oxygen, and nitrogen. So we can track that nitrogen. Well, Those nitrogens come from the diet, external sources, but they can come from our muscles. There's an interchange to this nitrogen pool that represents about 300 to 400 grams on average. I don't like to tie it to the gram numbers, but 300 to 400 grams on average. Cellular debris, autophagy, all of those things can create nitrogen. It is influenced, your nitrogen balance is influenced by thyroid function and by the use of energy. So when you're in ketosis, you're not eating sugar, you may use ketogenic proteins to make ketones or even glucose. We lose it in our urine, feces, and sweat. We lose nitrogen in our hair, nails, skin, and our GI tract. And then a large amount of positive nitrogen balance goes toward de novo protein synthesis, not just muscles, but other proteins in the body. The waste products of protein is seen in uric acid, it is seen in creatinine, and it is seen in blood urea nitrogen, which in humans is the commonest form of nitrogen excretion through the kidneys, through the gut, and we can monitor that to determine the nitrogen balance. Nitrogen flux depends on protein intake and then intrametabolism toward proteins by the human body, followed by the formation of those excretory products. And you either have a net increase, a net positive nitrogen flux where it's going toward protein, or mostly protein being broken down to sugar or as a waste product. So the most important interim stage is protein biosynthesis that is fixed and biologically controlled. That is fixed and biologically controlled. So all these athletes that say, oh, more protein, more protein, more protein, more muscle. That is only true to an upper limit of genetic capability. And then that extra protein has to be utilized, and you develop, instead of a positive nitrogen balance, a negative nitrogen balance. Growth is stimulated by human growth hormone, T3, T4, and insulin. That's a positive nitrogen balance. A negative nitrogen balance occurs under somatostatin suppression of HGH, TSH, and insulin, cortisol, and glucagon. So we've got to be able to look at nitrogen and see where these folks are. Are they in positive or negative nitrogen balance? And as we do that, we're going to look at creatinine. And creatinine, ideally in most tests, I want around 0.7 with a high GFR, a GFR above 60. Now, creatinine may be elevated due to kidney damage, from hypertension, from insulin-resistant diabetes. There are certain supplements that'll affect creatinine, especially if you're taking creatine. Coffee elevates creatinine. So these are all things to look for and to ask about when you see an elevated creatinine. But it typically signifies kidney function, especially when it's affecting GFR, and it's a warning signal. Blood urea nitrogen ideally should be 18 to 22. That is a net neutral nitrogen balance. If your BUN, if your urea production is low, we're talking about protein energy malnutrition. We're talking about either lack of protein consumption or a net positive nitrogen balance. And it really is the imbalance between the supply of protein and energy, and the body's demand for protein needs to be increased to ensure optimal growth and function. So we need to increase protein consumption. And in the worst cases, we see kwashiorkor. And I know we see kwashiorkor in Africa in starving children. But we also see it under obese conditions. We just don't call it that because we don't make the connection. Kwashiorkor is profound protein energy malnutrition, and we see that in some of our obese, malnourished patients. A high BUN, on the other hand, is due to protein-sparing gluconeogenesis and insulin suppression. So a fat-adapted person who's insulin suppressed on an ultra-low carbohydrate diet may have a high BUN where all that nitrogen, all that protein that they're taking in excess is being converted to sugar and then to fat by the body, and I'm not certain that's a very healthy way to be. Uric acid, human beings are not good at dealing with uric acid. Birds are. That's their primary source of nitrogen elimination. Uric acid, ideally, for me, should be below 5, but definitely below 5.5. It may be elevated in insulin resistance due to fructose consumption, fructose the sugar. It is also elevated in early ketosis due to autophagy and breakdown of the human body, particularly from purines and protein breakdown. But remember that uric acid has very potent vascular antioxidant capacity equivalent to vitamin C. So it's a useful molecule to have in the bloodstream, but not elevated. Uric acid may be elevated in insulin suppression as well, and I'm not sure how concerned to be about that at this stage. That jury's still out. We're tracking certain patients. But we absolutely know that elevated uric acid is associated with gout and uric acid kidney stones, and both of those are bad. Whether our insulin suppressed patients get that, I'm not certain. Urinalysis, early morning, I like the specific gravity to be around 1010 to 1015, and all of the numbers should be negative except ketones. And ideally, even though it's the dawn effect, I'd like to see a trace to up to 2+, 3+ ketones in the urine. You also want to look at the urine for crystals. Look for oxalic acid crystals or uric acid crystals. And guys, come on now. Calcium oxalate that forms these oxalic acid stones, and if your oxalates are high in your blood, it is very unlikely to come from our diet. The human body does not work that simplistically. Calcium oxalate is a spin-off of the Krebs cycle where it's dealing with an excess of energy, and that oxalic acid gets spun off, conjugated with calcium, and excreted. It is not due to oxalic acid in our diet. Under diabetes conditions, we also look for spilling of glucose, nitrates, protein, and infections in the urine. So now let's look at fat, the third macronutrient. Fat requirement has increased and is directly associated with Homo sapien evolution. And when it comes to fat, fat is just not one thing. We see fat as saturated, as monosaturated, and polyunsaturated fats. All three are important, and all three are contained in the fat that we eat. Now, on this slide, we're talking about fat as an energy source. And both the liver and the fat cells make energy from fat. We can make ketones in the liver. We can consume and make medium-chain triglycerides. And in the fat cells and in the liver, chronic excessive carbohydrate consumption is turned to triglycerides as the storage molecule of energy fat. So triglycerides represent fat as a source of energy. The length of the fat chains varies. So small C2, C4 are the ketones, C6 to C12, C14 are the medium chains that get directly absorbed into the bloodstream from the gut. Larger chains, C16 and up to C20, are typically made in the liver, made in the fat cells, because according to Jeff Volek paper, glucose, when it gets turned into fat, starts at a 16 carbon molecule, and these large molecules cannot be transported free in the blood like ketones and MCTs. So therefore, they have to be made into triglycerides, and triglycerides have to be transported in a transport molecule. So fat as energy, it can come from any of these, but if we lean heavily toward the triglycerides, especially if they're made by the liver, that has negative consequences. Now, the key thing about fat is it has a crucial structural component as well. And there are 4 elements to the structural components of fat in the cell membranes, in the organelles. And this is completely ignored by people when they calculate how much fat, how many grams of fat you should eat in a day, because nobody can tell whether that fat has to go structural or energy. The structural fats are cholesterol. And whether cholesterol is consumed or whether it is produced by the liver, that ratio is controlled by insulin. High insulin governs liver production, low insulin increases consumed absorption. But it's the same cholesterol molecule, and it's critical, it's crucial for cellular membranes. Ketones and MCT, medium chain triglycerides, are also part of the structural fat building blocks, because several cells can use ketones and MCTs to build longer fatty acids for incorporation in cell membranes. Structural phospholipids are produced by the liver and in fat cells. These are different than triglycerides, very similar, and they may have polyunsaturated, monounsaturated, or saturated fats. And this is the precursor molecule for building membranes. And then the final part that is crucial are the N3 and N6 polyunsaturated fatty acids. And I had a great conversation with a guy called Stephen Cunane who studies this. And he specifically told me that the human body has a rate-limiting step in the conversion of alpha-linoleic acid and linoleic acid toward DHA and arachidonic acid. So therefore, we have to, as humans, consume adequate amounts of 3-omega fatty acids as DHA and 6-omega fatty acids as arachidonic acid to have healthy membranes. Yes, folks, all of those that demonize PUFA, it isn't PUFA. They're vital, vital, vital for human survival, but it's the ratio of the 3 to the 6s in the membranes that is critical. So the structure of phospholipids affects membrane fluidity and integrity. If you've got a lot of saturated molecules and not a lot of cholesterol, you've got stiff membranes. If you've got a lot of polyunsaturated and monounsaturated, your membrane integrity, the length and the saturation of those phospholipids is crucial to membrane structure, and different membranes have different functions. But as you can see at the bottom here, the membrane is extremely complex. So why am I talking about this? Because the blood work reflects the substrates available for membrane integrity. Folks, lipoproteins are just FedEx vehicles. They are just transport molecules, and the different lipoproteins really reflect the different elements that are carried from cell to cell, from organ to cell. All of the lipoproteins transport triglycerides, phospholipids, cholesterol, and protein. That's all they are. They are transport vehicles. The concentrations of the different ones and the traffic is important. So what we don't want is traffic from the liver in a one-way direction to the fat cells, and there we see VLDL. If we see the traffic of LDL back to the liver and back to the cells, that's the traffic we want to see. We want to see fat going from fat cells to liver, which is the fat we've eaten in a ketogenic diet. We don't want to see glucose that's been converted to fat being transported to storage in the fat. That is a supply problem as opposed to a demand benefit. HDL, on the other hand, is just a scavenger molecule that collects cholesterol and transfers other forms of membrane and energy molecules to the LDL in the bloodstream. So traffic is more important than the absolute numbers. Size matters. Size matters because size determines traffic. The smaller molecules are going to be higher in cholesterol and protein and lower in triglycerides and phospholipids. And you want phospholipids and triglycerides to be outgoing with some cholesterol and protein. Incoming, you want cholesterol and protein coming back for deposition in the liver for disposal in the bile. So size does matter. And you want big fluffy LDL, big fluffy VLDL, big fluffy LDL, and small VLDL, small low number VLDL with big fluffy chylomicrons at mealtimes. So let's look at the blood work. How is that all reflected in the blood work? Well, the first thing is, folks, total cholesterol is irrelevant. I don't care. IDC, I don't care, because total cholesterol is a balance between hepatic production and dietary absorption, and storage versus release during weight loss, autophagy, enterohepatic bile circulation. So total cholesterol is relevant for me unless someone has xanthelasma or ARCUS. But generally, I don't care about the total. Oh my God, you're going to have a heart attack in 10 minutes. I don't care. The LDL cholesterol, especially the A particles, the big fluffy LDL cholesterol, I would like LDL cholesterol to be between 120 and 300. Which most doctors are going to have a heart attack on our patient's behalf because, of course, in the lipid heart hypothesis, LDL kills people. LDL does not damage blood vessels. It is a transport molecule for protein, fat, triglycerides, cholesterol, and phospholipids. And it should be high in triglycerides and high in phospholipids and relatively low in cholesterol. Yes, if the vessel's damaged, the LDL is going to dump some fat at that vessel injury level, but it does not cause the injury. HDL, your scavenger, large HDL scavenger molecule, ideally I want above 75, whereas triglycerides, the molecule that is made by sugar converting to fat as a protective device against hyperglycemia, I'd like to see that number below 75, which means you're not on a hyperglycemic diet. VLDL transports fat from the liver to the fat cells, and therefore we want the VLDL number to be low, which means the liver is a net receiver of energy rather than a producer of energy. I really don't find, in the most part, lipid NMR, oh, we must do lipid. No, I find it of no value because I can interpret exactly where someone is in terms of their biologic ketogenic journey based on LDL, HDL, triglycerides, and A1C. I don't need the lipid NMR unless they may have a genetic abnormality. Obviously, if we do it, we're looking for LDL and HDL particle number to be high and the particle size to be large, which gives us the A pattern, with VLDL particle number and size to be small. I don't look at ratios, but the ApoA-B100 ratio is the one to consider. But those I can interpret from the blood work directly. Folks, we're obsessed, or the healthcare system is obsessed with lipid particles, and we are completely ignorant to glucose, A1C, insulin, C-peptide. It's worth looking at the lipid particles, but to obsess about them, every patient can tell you exactly what their cholesterol is. None of them can tell you what their insulin is, and that is upside down. So now we've looked at the macros. Let's look at some of the markers of inflammation that come from sugar in the GI tract, intravascularly, in the interstitium, intracellular, and organ specific. White blood cell count. White blood cells live in the blood vessels, and ideally in someone who does not have global intravascular inflammation, ideally in a ketogenic fat-adapted person, their white cell count should be less than 5. Of course, acute infections, other things can trigger that, but it speaks to a global quietening of the intravascular immune system. So I like the white cell count to be below 5, but I will look at the white cell breakdown. I want the neutrophils at 50 or lower. I check the monos, the basophils, the eosinophils, because they speak to GI inflammation, parasites, acute inflammation, histamine, autoimmune dysfunction. But globally, I want that white cell count to be low, and having it in the 3s and 4s is absolutely fine. Don't panic. Hemoglobin, I just want that in the normal range. If it's not in the normal range, I look below, but I also will ignore normal and look at the MCV, MCH, MCHC, and RDW, which speak to red blood cell size. And we want to look for microcytic or macrocytic anemia or red blood cell size, because that speaks to blood loss, for example, in polycystic ovarian syndrome, H. pylori in the stomach, other GI bleeds. And it also speaks, more importantly, to iron deficiency or iron overload, to folate deficiency, to B12 deficiency, macro and microcytic anemia. I really don't look at reticulocyte count. You can if you want to, if someone's lost blood, but I really don't look at retics. Platelets I want in the normal range. However, if someone's on aspirin or someone's on an anticoagulant or blood thinner, it's worthwhile to check their platelets because, for example, Xarelto significantly decreases platelet counts in a number of people. I do not use ESR or CRP. I don't find them useful as a marker of inflammation. Yeah, oh, your ESR is high, oh, your CRP is high. Who cares? It's not telling me anything specific. I want numbers to tell me why they have the inflammation. And same thing with PT, PDT. I only really look at them for liver disease or anticoagulation, but I rarely test them except perioperatively. Now, the liver numbers. Alkaline phosphatase is a very important liver marker. It is not specific to the liver, but it is typically and most commonly a direct marker of non-specific hepatic and biliary injury. It is increased in liver inflammation, and the commonest cause of liver disease is non-alcoholic steatohepatitis, inflammation of the liver, as opposed to a plain fatty liver, which is non-alcoholic steatosis. So with steatosis, with fatty liver, we see an elevation in AST and ALT, the two enzymes that break down aspartate transaminase and alanine, aspartate and alanine being amino acids. Ideally, for a normal liver, for a non-fatty liver, I'd like to see AST and ALT in the 10 to 14 range, with a low ALK phos in the 50 to 55 range. Sometimes we see ALK phos high with normal AST and ALT. That is recovering steatosis, but if I'm not sure why the ALK phos is high with normal AST and ALT, you can always look at the gamma-glutamyl transferase, which ideally should be 10 to 15. If that's low, we know the ALK phos is coming from somewhere else, or it's a residue of improving fatty liver. The AST and ALT come from the breakdown of amino acids, are increased in fatty liver syndrome, or increased in carbohydrate addiction, but also reflect protein turnover in someone that's insulin suppressed. So sometimes we see a rise in AST and ALT without a commensurate rise in ALK Phos in our veteran carnivore group. Bilirubin I only look at for biliary obstruction. Electrolytes. These are really not important, but I use them as a speaking discussion point. And it's incredible how stable, and the whole body is geared towards sodium stability. Sodium should be a flat line around 140. And it's the blood sugar that fluctuates. Both glucose and sodium act exactly the same way in the blood vascular space. They retain water. But if your sodium is stable, sodium will regulate blood pressure and blood volume. And the only thing you need is an abundance of sodium. The human body is designed to get rid of excess sodium, but it struggles with a deficiency of sodium. However, the human body is also designed for a very low blood sugar, and it struggles with high blood sugar. Because what happens is that sugar goes up, it sucks a lot of water, it's hydrophilic, sucks a lot of water into the blood vascular space. And then the sugar gets used up, the sugar gets into the cells. Now you're left with all this excess water. How the devil are you going to get rid of it? You become edematous. It goes into the subcutaneous tissue. So very important discussion of sodium stability and blood glucose fluctuation when you come to treating blood pressure. Calcium levels, I typically want around 9 to 10, 10.2. If they're higher, check PTH. We sometimes see parathyroid adenomas. But I also, when I'm looking at calcium, I look at the vitamin D level. And vitamin D is actually not a vitamin, it's a steroid hormone, usually suppressed by insulin, usually blocked by insulin. Its precursor is actually cholesterol. But typically I'm looking at vitamin D, and I typically want it between 40 and 80. But here's the problem, folks. I really don't know. And here's why I don't know, is because pretty much everybody that I test who's not supplementing has a super low thyroid. I'm doing a study right now on a group of medical students aged 22 to 28. Almost all of them have low vitamin D levels. Are they just profoundly abnormal? Is everybody that walks into my office really abnormal? Or perhaps the normal values are a problem? So I really don't know what to make of vitamin D3 levels, because I'm starting to believe that the normal range is the problem. But I'll still treat because I don't know. Protein, globulin, and albumin in the bloodstream are carrier proteins made by the kidney and are made by the liver and are reflective of liver and kidney function. Now, the iron indices are important to look at because iron is crucial. Iron flux is very, very important to health, particularly brain health and hemoglobin. So I like my total iron to be between 60 and 100. High or low is a concern. And if it's low, we look for sources of blood loss, PCOS, H. pylori, so they may need a colonoscopy. And also we look at iron intake. So we look at loss as well as iron deficiency. TIBC is a calculated number. Percentage saturation is also a calculated number. And I like the TIBC to be 300 to 400, the saturation to be 25 to 40%. The reason I look at these, because I am looking at anemia, potential precursor to iron deficiency anemia, and saturation and TIBC calculated numbers are cheaper as a test than to do transferrin. I will sometimes do transferrin, which is the transport molecule of iron in the bloodstream, but transferrin is a liver protein and may be low in malnutrition or inflammation, particularly inflammation that we've seen with COVID, for example, and it is elevated in iron deficiency anemia. So it gives me additional clues. Ferritin is a very important molecule for me. Ferritin is an intracellular molecule that binds iron, but ferritin is indicative of intracellular inflammation. It is a marker of intracellular inflammation, but also correlates with iron stores. It opposes transferrin. So if both your transferrin and your ferritin are high, that may mean that you're dealing with inflammation. Ferritin is also elevated in extended fasting. Now, thyroid numbers. Folks, 82% of the new patients that walk into my office are on a thyroid medication. And when I ask them, why are you taking this thyroid medication? Oh, I've been taking it for 15 years. Why? Because I've got low thyroid. I'm hypothyroid. Hypothyroidism is not a diagnosis. Hypothyroidism is an observation, and most doctors make that observation based on one number called TSH, thyroid stimulating hormone. And if it's high, off you go, here's your pill. And they monitor TSH. That is an awful way to understand thyroid biology, thyroid hormonal biology, which is separate from the cancers. So the question when these patients come in, are they on T4 and are they on T3, or such as a Synthroid or a Cytomel, are they on a mixed medication like an ARMOR? It's important to know that because obviously that's going to modify their numbers. But at entry to my practice, I always check a TSH, which I want between 0.5 and 3.5, preferably around 0.5 to 1. Total T4, free T4, total T3, and the most important number for me, the active thyroid hormone, is free T3, and free T3 is the feedback hormone for TSH. And those are the ranges I want them in. T4 also gets converted to T3, and insulin blocks that conversion, but so does Hashimoto's disease. I will sometimes get a reverse T3, but I found it less valuable than has been reported by other people. However, it is crucial, because, especially in our metabolic patients that eat a lot of grain products, a lot of them have autoimmune disease triggered by sugar, but triggered primarily by grain products. It's part of what I call celiac disease. It's an autoimmune type disease, and we always test thyroid peroxidase and thyroglobulin antibodies, because if they're elevated, we're looking at Hashimoto's disease. And sometimes the antibodies are elevated despite having normal numbers, and sometimes we may even need to treat even though these numbers are normal. But we can get these patients into remission by a low carbohydrate diet. The thyroid stimulating antibody I only use when somebody has a potential for Graves' disease, or when their thyroid is super low and we don't know why. I never check iodine levels. You know why? Because if there's any problem with thyroid, we're going to tell people to supplement with 150 to 220 milligrams of iodine, either as iodized salt together with their Redmond's or pink Himalayan salt, or they add a couple of drops of Lugol's. So I don't ever check iodine levels because I'm going to supplement or tell folks to supplement anyway as part of their salt. The female the sex hormones I do look at because they're very common concerns for patients, but they also tell a story. So with my females, I look at the free testosterone, and the free testosterone is more important, and I like that to be around 0.2 to 2. Higher than that, we see in PCOS, and those PCOS patients typically have a low estrogen and progesterone. We also look at DHEA sulfate, and I want to see that low. If it's higher, patients may have insulin resistance and PCOS. Their free estradiol, which is the active component of estrogen, and progesterone, that ratio between testosterone, estrogen, and progesterone is controlled by insulin, but also genetically controlled. So in lipedema patients, we have a high PE ratio and a normal testosterone, or a low testosterone for females. With a gynecoid, we have high estrogen, low progesterone, and normal testosterone, but high testosterone and PCOS. So they are predictors of what the genetic outcome for some of these patients are, because your PCOS patients will rarely have diabetes. They tend to be more obesogenic because they produce a lot of insulin. So one of the questions and the concerns I have is, why are so many peri and postmenopausal women on testosterone? They have all these testosterone pellets implanted. Their testosterones, when they come in, are often higher than a lot of my male population. And I have some concerns about the way that some of these patients are managed by their gynecologist. Now, I'm not a gynecologist, but we see ridiculously high testosterone levels, and certainly same thing with estrogen and progesterone. We see them off the map. I don't typically check LH and FSH. My males commonly have low testosterone because of insulin resistance. And when insulin sensitivity is restored, we see a rapid rise in testosterone. For the free testosterone, I want it between 50 and 200. And ideally males between 5 and 800, maybe 6 and 800. Often we see it very low in the 20s and 30s, and we see the testosterone, the total testosterone in the 200s. And we watch that and we track that, and it increases. But so many men come in on testosterone supplementation that flatlines your testosterone and interferes with all the hormonal feedback. So I'm not in favor of testosterone because of some masculinity identity crisis. So I'd be very, very cautious about using testosterone as a supplement. Very common in the United States. PSA I routinely check, not that it's a metabolic issue, primarily as far as I'm aware, but I do check it because it is an important screening hormone, and we see prostate problems very commonly. Minerals, vitamins, and other common tests. I always check RBC folate, especially in child-producing or child-rearing female patients, because that can lead to spina bifida, and it's a very common deficiency. Almost everybody in my practice, because of the internet, is taking magnesium. Well, we want to look at red blood cell magnesium levels because very often they're overdosed. Same thing with B12. We see B12s above 2,000 units. Ideally, I want B12 between 6 and 800, but we monitor these. We occasionally look at B1, B6, and other B vitamins, A, C, E, K, but I really am not in favor of testing this routinely. When someone's on a protein pump inhibitor, I want to know what their B12s are. So really, we're looking for an indication to test rather than a global test. Same thing with the rheumatoid factors, the anti-nuclear antibodies, the pituitary hormones, the adrenal hormone testing. It always should be 24-hour urine analysis for metanephrines. This whole adrenal fatigue thing, come on, folks. Ask me about that, but no. That's an internet gimmick. Same thing with parathyroid hormone. We sometimes see MEN, and we see some of the autoimmune diseases. Test is needed. Here's where I do have a problem with some of the screening tests that are done by so many of the doctors out there. In my opinion, they have little value, and they just confuse the pictures and are really a forum for throwing medications at patients rather than helping patients to help themselves. Stop looking for hen's teeth. Stop looking at numbers to treat. And be serious. Adrenal fatigue is garbage. My adrenal's tired. My adrenal's not tired. It is hormonal imbalance that you can pick up by other ways. Throwing adrenal or corticosteroids at patients is ludicrous. It upsets the entire balance, and yet we see it quite commonly. Adrenal fatigue is a consequence of insulin resistance, but does not need to be measured. It can be assumed, and it gets better. Same thing with all the celiac disease. We see upper endoscopies, we see biopsies, we see all these IgA and IgG antigliadin. You know what, folks? Tell people to stop eating carbohydrates. No carbohydrates, no celiac disease. No human being is not allergic to grain products, to gliadins. So it's universal. Sometimes it's clinically obvious, sometimes not. You don't have to test for it. Get them to stop eating their grain products and they're going to be just fine. Same thing with histamine testing. We see all this mastocytosis, and you can do those tests, but it confuses the picture. I get so many people, my histamine this, and they won't eat this and they won't eat that, and they almost have to stop breathing because the air they breathe triggers their histamine reaction. It's just rocking horse manure, folks. Same thing with SIBO. Oh, my hydrogen test, my methane test. I had a patient come in this morning with 2 pages of notes about all the bacteria and things they found on it. SIBO is really not a concern for me. Yes, go to town on me. It is not a concern for me. Most of the irritable bowel that we see, most of the reflux, most of the intestinal problems is not because of bacterial overgrowth in a normal intestine unless someone's had surgery. It is usually a neurologic problem with the nerves, especially the vagus nerve, that creates abnormal contraction, which is an insulin resistance disease and a diabetes disease. SIBO is really rare as rocking horse manure, and it's a distraction. It's a distraction. The small intestine is relatively sterile relative to the colon. But do test H. pylori. About a third of my patients are positive for H. pylori, and often it's in conjunction with symptoms, anemia, and a high risk of cancer. So please test for H. pylori by breath test. More wallet biopsies, leptin, blood cortisol, which is a fickle little molecule that doesn't mean anything, CRP, testing for omega and 3s and 6s, as well as all the other fatty acid testing and amino acid testing. Is there a place for them? Yes, but it's a pimple on the elephant's ass. Same thing with the allergy testing. If someone has a severe reaction, test for it. But oh, you got a milk allergy. How do you know that it's a milk allergy and not just someone who hasn't had milk for a long time? We just don't know that. Same thing with upfront trace element testing. If you're getting into these weeds, folks, for someone who has metabolic syndrome, someone who has type 2 diabetes, or someone who's morbidly obese, you really are testing serum rhubarb levels, and you're focusing on the pimples on the elephant's ass, and you're ignoring the elephant. These tests are typically wallet biopsies that become a source of revenue for the practice, and they really have very little clinical relevance in my life. And I know, go to town on me, blast me for that, but until you are a perfectly healthy, normal human being, these tests are generally unwarranted. If this is who you look like, you don't need to know if you've got SIBO. Okay? His blood numbers were all over the place. This is a 16-year-old. So the best therapeutic intervention for that person is to put him on a low carbohydrate, high fat, ketogenic diet, a diet that restores insulin sensitivity over time by forcing the body into a state of ketogenesis. We want an insulin of 4 to 6, a C-peptide of 1 to 1.2, glucose in the fasting glucose 80 to 85, A1C at 5.2 or lower, triglycerides below 75, HDL above 75, LDL 120 to 300, and eventually a BMI below 25. That, folks, is called normal. And we use our ketogenic blood work to track person to normal. And here you see in Archie, over a 3-year course, 3 years, but you see how he's resolved his metabolic syndrome. Not with medication, not by testing his allergies and his SIBO, but by a ketogenic diet. And same is true for every one of these folks. Restoring insulin sensitivity results in diabetes remission, results in remission of insulin resistance. And every one of these folks has benefited nutritionally and biologically from a therapeutic carbohydrate restriction diet, not by throwing a bunch of pills at them. Some of them transiently needed medication, but look at them now. So the ideal best therapeutic intervention is a low carbohydrate, high fat lifestyle that can be monitored with with the ketogenic blood work. But we don't have to throw medications at all the numbers. This intervention is the best intervention. It's the most powerful prescription you can write. But it needs to be a ketogenic pyramid for the rest of your life, not just toward disease resolution. Restoring the fat and glucose energy ratio, restoring cellular structural integrity is what metabolic health is about, and we can measure that. Higher protein consumption likely drives positive human genetic evolution. But folks, we've been sidetracked. We've been sidetracked by so many people who come with an idea, come with a belief, and then look for evidence to support that belief. And that is what screwed up our society. Evidence-based science is not looking for evidence to support your position. Science is deciding your position based on the strength and merits of the evidence for and against, and being prepared and able to change your mind. That is what ketogenic blood work helps you to do, and to track your patients toward nutritional health. I am the Carb Addiction Doc. Thank you so much for the platform.